Our talk today is on the approach to the critically ill obstetric patient. Critical illness in pregnancy may result from a worsening of underlying cardiac or pulmonary disease or the onset of a unique pregnancy-related illness. Adaptive changes occur in the circulation, respiratory system, gut, and kidneys to meet the increased metabolic demands of the mother, fetus, and placenta. Knowledge of the normal changes in maternal respiratory, cardiac, and acid-base physiology in pregnancy is essential to distinguish between the adaptive and pathological changes. The assessment, monitoring, and treatment of the gravid patient in the ICU must take into account both the maternal and fetal well-being and requires a multidisciplinary approach to care, which includes the intensivist, the obstetrician, the maternal fetal medicine specialist, the anesthetics, neonates, and nursing staff. Obstetric patients require ICU admission for organ dysfunction caused by obstetric or medical disorders or both. Obstetric disorders are responsible for 50 to 75% of ICU admissions, with preeclampsia, obstetric hemorrhage, and pelvic sepsis accounting for 80% of obstetric ICU admissions across all geographic regions. Approximately 12 to 45% of ICU admissions are during the antenatal period, 50% during labor or the first 24 hours after delivery, and up to 15% are later in the postpartum period. Correspondingly, 25% of maternal deaths occur antenatally, 26% intrapartum, and up to 50% postpartum. This just looks at the common causes of critical illness in pregnancy. The most common obstetric causes that we have seen is a hypertensive crisis, severe preeclampsia, HELLP syndrome, eclampsia, abruption placenta, uterine rupture, and sepsis. Non-obstetric causes include acute respiratory distress syndrome, urosepsis, and diabetic ketoacidosis. Pre-existing diseases that may worsen pregnancy include valvular heart disease, cystic fibrosis, lupus, epilepsy, and sickle cell disease. Increased susceptibility of these illnesses during pregnancy include acute kidney injury, urosepsis, varicella pneumonia, H1N1 and COVID-19, gestational diabetes, intracranial bleeds, and pulmonary emboli. Although ICU admission rates are comparable in developed and developing countries, maternal mortality differs greatly. In 1990, the maternal mortality ratio was 26 in developed nations and 430 in developing nations. Over the last 24 years, with improvements in public health systems, better access to health care, improved intensive care admissions, the maternal mortality rate has declined to 16, that is a 38% decrease in developed countries, and 230, which is a 46% decrease in the developing countries. But it is still short of the Millennial Development Goals of the WHO, which targeted a 75% reduction in maternal mortality. Pregnant women requiring maternal critical care unit admission are relatively low in developed countries, but in our country, the admission rates of critically ill patients range from 3 to 8%. Two-thirds of pregnant women requiring critical care often unanticipated at the time of conception. South Africa is the only country in Africa to have a sustained and functional national confidential inquiry into the maternal death committee. In the latest report, non-pregnancy related infections was the leading cause of maternal mortality. Hypertension caused 18% of all maternal deaths, with complications of the central nervous system and of the circulatory system each occurring in 38% of cases, respiratory system complications in 15%, and renal and hematological systems each in 9% of cases. Obstetric hemorrhage occurred in 16% of maternal deaths and was complicated by hypovolemic shock, DIC, and cardiac failure. Pregnancy-related sepsis was found in 10% of maternal deaths and was complicated by septic shock, multi-organ failure, respiratory failure, and immune system failure. Also of note, cardiac disease caused 5% of maternal deaths. The initial assessment of a sick patient should be no different from a critically ill non-pregnant patient. Circulation, airway, and breathing are assessed, and the patient is stabilized and transferred to an appropriate level of care. The components of the care pathways for the critically ill pregnant woman include recognition and response. Recognition is the detection of clinical decompensation in a pregnant woman that is life-threatening but potentially reversible and should be transferred to the appropriate level of care. Response is the provision of a multidisciplinary care plan with obstetric interventions and specialty interventions. So it is imperative to highlight the importance of early recognition and management of severely ill pregnant women with the routine use of maternal early warning scoring systems for obstetric patients. Early recognition of critical illness is essential for a favorable outcome for mother and baby. Prognostic criteria such as the Apache scoring and the sequential organ functional assessment score may predict mortality. The SOFA score looks at 6 variables with a score from 0 to 4. It is done initially at admission, and the highest admission risk score is used, and this may predict mortality, and a second score is done 24 to 48 hours later post-admission. The quick SOFA score requires only clinical data for assessment and thus can be performed quickly without waiting for any lab results. Let's look at physiology of pregnancy. Maternal cardiovascular changes start in the first trimester, peaks at the end of the second trimester, and then plateaus until delivery. A normal pregnant patient is an anatomically challenging and physiologically compromised patient. These changes are exaggerated when there is an underlying pathology such as eclampsia, pulmonary edema, and trauma. There are several important physiological changes that may influence resuscitation in a pregnant woman. There is an increase of up to 50% in cardiac output during pregnancy due to the increased stroke volume and maternal heart rate. The mean arterial pressure is reduced due to the decreased systemic vascular resistance that may be mediated by increase in progesterone and estrogen. The gravid uterus may compress the aorta to produce an increased afterload and compress the inferior vena cava, leading to a decreased cardiac return, which can lead to hypotension in the supine position, which is the most favorable position for resuscitation. Left uterine displacement is a very important maneuver during resuscitation to improve cardiac output, as it enhances the preload by more than 25% in a term patient and also reduces the afterload. It can be done either manually by lifting the uterus with your hands upwards and displacing it towards the left side, as you can see on the picture, or by putting a wedge under the right hip. Therefore, pregnant patients in a supine position in theatre or ICU should also be tilted up to 15 to 20 degrees to either side using a wedge to displace the uterus. Let's look at the respiratory changes. So progesterone-mediated increase in tidal volume will result in an increased minute volume, a decreased partial pressure of carbon dioxide, and respiratory alkalosis. Elevation of the diaphragm by the gravid uterus and hormonally induced changes may reduce functional residual capacity, residual volume, and expiratory reserve volume. This, together with the increased oxygen consumption, makes the pregnant woman and fetus more vulnerable to hypoxia in the event of hypoventilation or apnea. Delayed gastric emptying and a relaxed esophageal sphincter may increase the risk of aspiration during intubation, seizures, and altered mental status. Adaptive alteration of the helper T-cell immune response to facilitate immune tolerance of the fetus could also increase the risk of some infections in pregnancy. Let's look at the initial assessment. So, how would you approach a maternal collapse? It can result from a number of causes, and a systemic approach from head to toe should be taken to identify the cause. So, we're going to use the CAB approach. So, the crux of circulation is to maintain adequate uteroplacental perfusion. Common shock states in the pregnancy should be appropriately and aggressively treated with 2 large bore IV lines and minimally invasive monitoring, an arterial line and a central line if possible. If the gestational age is greater than 20 weeks, it is ensured that left uterine displacement is maintained using a wedge. Crystalloid resuscitation and appropriate transfusion triggers and endpoints should be followed. And for sepsis, revised surviving sepsis guidelines should be followed. One should not hesitate to start appropriate vasopressors and inotropes early with the fear of fetal transfer. The thumb rule is what is good for the mother and stabilizes the mother is always good for the fetus. Airway evaluation and management remains the top priority, as pregnant patients tolerate hypoxemia very poorly and they desaturate very quickly. Furthermore, the risk of difficult intubation in pregnancies increase up to 10 times, and the clinician involved in the patient care has to be well versed with the difficult airway guidelines. In the majority of cases, the use of simple methods is all that is required to open the airway, such as suction to remove secretions, the use of the head tilt chin lift maneuver, or the insertion of an oropharyngeal or nasopharyngeal airway. It is important that everyone knows the indications for intubation. The adequacy of gaseous exchange must be assessed and efforts to maintain it. Supplemental oxygen, high flow, and non-invasive ventilation have all been reported to maintain targeted gaseous exchange. Intubation is performed if the ventilation targets are not achieved. The basic principle used to put a particular case together and decide what management plan required is to evaluate each organ system systemically for signs of a systemic response or organ dysfunction. If an abnormality is detected, this should serve as a trigger to investigate and initiate support of that particular organ. Thereafter, one must identify the cause and address the cause. In this way, on examination, each potential problem identified on history can be evaluated and the systemic effects of the problem documented and managed. As an aid, the organ systems are grouped into the acute life-saving Big Five, the forgotten four, and the organ system central to obstetrics, the core one. Early identification and correct assessment should be done at patients at risk of severe acute maternal morbidity, which is defined as organ dysfunction or established organ dysfunction or failure. This basically looks at the diagrammatic sequence of events from a normal healthy pregnancy. So the clinical insults should be picked up at screening. There should be early detection of the systemic inflammatory response. And if it's not picked up before this, early critical care admission for those patients with organ dysfunction and organ failure to prevent maternal death. So let's look at the Big Five. We're going to start from head to toe. So looking for signs of central nervous system failure, there are many signs that you can clinically look for, such as drowsiness, confusion, convulsions, delirium, reduced level of consciousness, hypertension or hypotension. Investigations you can do at the bedside include a blood glucose, a urea and creatinine, LFTs, a blood gas and saturation, and if needed, a CT brain to look for intracerebral hemorrhage and press. Supportive treatment will depend on the cause, for example, magnesium sulfate, oxygen, or glucose. Looking at the circulatory system, clinical signs include hypotension or hypertension, tachycardia above 90 beats per minute, cold and clammy extremities, pulmonary edema, or arrhythmias. Special investigations include a chest X-ray, ECG, echo, and a blood gas. For shock, adequate venous access you should have adequate venous access with a high flow or central venous pressure monitoring as well. Fluid replacement and inotropic support, and for hypertension, you should control the blood pressure to prevent convulsions and intracranial hemorrhage. Clinical signs of respiratory failure include increased respiratory rate above 20, the use of accessory muscle use, and central or peripheral cyanosis. Special investigations would include basic SATs less than 90%, a blood gas, which can reveal a respiratory acidosis or an alkalosis, and a chest X-ray. Supportive treatment includes oxygen via nasal prongs or face mask or CPAP, or if needed, intubation and ventilation. If there is a pneumonia, treated, and if there is pulmonary edema, treated. Lastly, looking at the liver failure, clinical signs that we can look for is jaundice, hepatomegaly, co-colored urine in HELLP syndrome, and severe epigastric pain. Special investigations also includes basically a blood glucose, LFTs, HP, and a liver ultrasound to exclude a liver hematoma. The most important clinical sign for renal failure is a reduced urine output, either defined as oliguria, which is less than 0.5 ml per kg per hour, or anuria, or very concentrated urine. Special investigations include a urine dipstick, raised UNE, and urine microscopy. Supportive treatment includes fluid replacement and electrolyte shifts, and if there is progressive renal failure, nephrology input for possible hemodialysis. So, a systemic 5-step approach is recommended to enhance maternal and fetal outcomes, and we all know that step 1 is to call Dr. Moodley when we have a sick patient. So one of the major areas of substandard care identified in the Saving Mothers report was the initial poor assessment of the patient, which occurred in about 30% of cases. So we're going to go through the 5-step approach now. So step 1 is to distinguish between a medical or obstetric disorder. Manifestations of medical disorders closely mimic obstetric disorders. For example, preeclampsia, TTP, and SLE may all present with hypertension, proteinuria, a raised creatinine, thrombocytopenia, and seizures. The distinction is important because specific treatment is available for most medical disorders, whereas treatment options are limited for obstetric disorders. Prompt delivery will reverse the progression of many obstetric disorders, but may not alter the course of a medical disorder. Multi-organ failure is common in obstetric and medical disorders. Renal failure and coagulopathy in pregnancy deserve a special mention. Acute renal failure is common because of the altered systemic and renal hemodynamics in pregnancy. Although Although acute tubular necrosis is the usual underlying pathology, up to 20% of obstetric renal failure is due to acute cortical necrosis, which is a form of severe ischemic renal damage that occurs when shock is accompanied by microvascular thrombosis due to DIC. Women with acute cortical necrosis have anuria rather than oliguria and may be left with significant residual renal dysfunction requiring chronic dialysis. Thrombocytopenia and DIC are present in many obstetric patients, and all pregnant women in the ICU should routinely undergo a DIC screen or take as used in some centers and available at type work. Many obstetric disorders will improve rapidly after delivery, and urgent delivery may be life-saving. At times, urgent delivery is required for fetal distress, and sometimes the time required to stabilize the maternal organ function may further compromise the fetal outcome. The maternal risk from urgent delivery should be balanced against the risk to the fetus by delaying delivery. As a general principle, maternal well-being always takes precedence over that of the fetus. Another situation involves the periviable period, where termination of pregnancy may benefit the mother, and neonatal outcomes are extremely poor. The mode of delivery, being either vaginal or caesarean section, is best determined by the indication for delivery and the maternal clinical status. Vaginal delivery may not be feasible in most emergency indications, as the duration of labor is unpredictable. Also, 70% of critically ill patients in the ICU are usually delivered by caesarean section. Elective caesarean sections is normally performed under regional anesthesia. However, in patients with shock, respiratory distress, seizures, and coagulopathy, the risk of hypotension and local hematoma formation is significant. Therefore, general anesthesia may be preferred in these women. So it is vital in this situation to have a coordination between the intensivist, the obstetrician, the anesthetics, and neonatology as well. The next step is to correct the physiological derangements and minimize any complications during delivery. 2 doses of betamethasone to facilitate fetal lung maturation is given if time permits. Hypotension and hypovolemia should be corrected, and the lethal triad for fetal demise, being hypotension, hypoxia, and anemia, should be minimized or prevented. Intubation may be required for airway protection or mechanical ventilation or both. Seizures and severe hypertension must be controlled. Anticoagulants are discontinued, and the appropriate blood products should be administered to correct anemia, thrombocytopenia, and coagulation abnormalities. The timing of administration of blood products is critical, especially in a vaginal delivery, since labor may last for several hours. The goal of organ support should be giving best to both the lives, the mother and the fetus. The bottom line being is what is good for the mother is good for the fetus. So we're just going to go through the common conditions seen in critical care. So let's look at respiratory failure. So pregnancy results in specific changes in respiratory physiology, as we have now discussed. However, patients with acute respiratory failure during pregnancy or the peripartum period generally present with respiratory distress. They are typically short of breath and unable to complete sentences. They're usually confused, agitated, and cyanotic. Most pregnant patients will breathe more rapidly and shallowly than non-pregnant patients with acute respiratory failure, and may be using the accessory muscle of respiration. Auscultatory findings vary, but it may include crackles, rhonchi, or wheezes. The initial management is the same regardless of the cause of the acute respiratory failure. It's focused on oxygenation and stabilization of the patient, and undertaking a brief history and examination to determine the cause. Supplemental oxygenation should be administered, and the preferred method of administering the oxygen will depend upon the severity of the hypoxia. For most patients with mild hypoxia, administration by nasal cannula may be sufficient. For severe hypoxia, generally might require face mask, high flow, or non-rebreather mask. Oxygenation should be monitored continuously by pulse oximetry. Adequate fetal oxygenation requires a maternal arterial oxygen tension of more than 10 kilopascals, which corresponds to a saturation of 95%. Mechanical ventilation may be required, and the decision about whether to intubate the patient should be considered in the context of the pregnancy. Non-invasive ventilation has been reported to be successful in the management of acute respiratory failure during pregnancy. The potential benefits of non-invasive ventilation include the avoidance of intubation and sedation, as intubation may be difficult during the pregnancy and peripartum period, especially later on in pregnancy. Similar to a non-pregnant patient, it should be initiated in a monitored setting and reserved for patients who are alert and have the ability to protect the airway. Monitoring includes arterial blood gas, which will quantitate the severity of the ventilatory abnormalities, and it also guides your ventilator adjustments. The chest X-ray is used to narrow the differential diagnosis and in an intubated patient and may confirm the tube position. Point-of-care ultrasound is a diagnostic tool used with the increased frequency in the ICU setting to diagnose cardiopulmonary pathology in critically ill patients. There are specific ultrasound patterns seen for a normal lung, a pneumothorax, interstitial edema, and pneumonia. It was not specifically designed for the use in pregnancy, however some data suggests that it may be effectively utilized to assess acute respiratory failure during pregnancy. So looking at cardiovascular disease, maternal cardiac disease and peripartum cardiomyopathy is a major cause of maternal morbidity and mortality encountered in the ICU. In the past, rheumatic heart disease was the most common form of cardiac disease in pregnant women, and it still predominates in developing countries. However, congenital cardiac disease is now the most common form of cardiac disease complicating pregnancy in the developed countries, in part because advances in the treatment of congenital heart disease has made it possible for these children to reach adulthood and attempt pregnancy. One of the challenges for the clinician is how to distinguish between these normal signs of pregnancy and similar signs that may indicate underlying cardiac disease. Lastly, looking at pulmonary edema, acute pulmonary edema occurs in approximately 0.8% of pregnancies. It's a common complication of severe preeclampsia and eclampsia, and it's often accompanied by dysfunction of another organ system such as renal failure, hypertensive crisis, cardiac failure, and cerebral edema. It may be associated with preeclampsia and eclampsia and is often multifactorial in origin, the most common being iatrogenic fluid overload and left ventricular dysfunction. The clinical presentation is usually shortness of breath, increased rest rate, tachycardia, hypoxia, and diffuse crackles, and the chest X-ray usually reveals bilateral airspace disease. Most patients with pulmonary edema will respond well to supplemental oxygen, fluid restriction, and diuresis. Mechanical ventilation may be necessary, but most cases usually resolve within 12 to 24 hours. The most common cause of mitral stenosis amongst childbearing age is rheumatic heart disease. In women with moderate to severe mitral stenosis, the increased cardiac output and heart rate associated with pregnancy can result in an increased left atrial pressure, leading to complications such as atrial fibrillation and pulmonary edema. In a review of publications between 1985 and 2019 on pregnancy outcomes in women with mitral stenosis, maternal mortality for women with severe mitral stenosis was 3%, and for women with moderate stenosis was 1%. As a result, if severe stenosis is recognized before pregnancy, percutaneous mitral balloon valvotomy is recommended. Beta blockers are the mainstay of therapy for patients with mitral stenosis, and pregnant women with mitral stenosis who develop atrial fibrillation should receive anticoagulation. Those with persistent symptoms despite medical therapy may be considered for valve intervention during pregnancy. The management of labor and delivery in a cardiac patient requires a collaborative management by obstetricians, cardiologists, and anesthetics. In terms of the anesthetic, intramuscular or intravenous opioids may be used, but the epidural anesthesia is highly effective and is recommended because it lowers pain-induced elevations of the sympathetic activity. Systemic arterial pressure and heart rate are routinely used and as required by the patient's condition. For nearly all patients with cardiac disease, vaginal delivery is preferred to cesarean delivery since vaginal delivery generally poses a less cardiac risk. Cesarean delivery is generally reserved for obstetric indications. However, urgent cesarean delivery is suggested for patients with advanced cardiac failure and hemodynamic instability despite treatment. A planned daytime induction is the most practical, and the timing of induction is individualized, taking into account the patient's cardiac status. A long induction in a woman with an unfavorable cervix should be avoided, and from a practical point of view, it may be useful to plan the induction so that delivery occurs during the working day when all hospital services are available. Once in labor, the woman should be placed in a lateral position, and delivery may be assisted by forceps or vacuum extraction as needed. The principles of resuscitating a pregnant woman are nearly the same as resuscitating a non-pregnant woman. However, one has to consider that there are two lives in a pregnant woman, the woman and the fetus. In the event of cardiac arrest, published guidelines should be followed, and the common causes of cardiac arrest in pregnancy can be remembered by either the acronym ABCDE UPS or the 4 H's and 4 T's as we know. And it basically is anaphylaxis, anesthetic, bleeds in the brain, the liver, eclampsia, embolus, uterine, pulmonary, placental, and sepsis. The ABC and CAB approach should proceed simultaneously as they are prone to severe hypoxemia. The supine position with left uterine displacement is recommended during chest compressions, and a standard 200 joule shock is given. If return of spontaneous circulation cannot be established within 4 minutes of effective cardiopulmonary resuscitation, a perimortem caesarean section should be done, with delivery ideally achieved within 5 minutes of cardiac arrest, as this maximizes maternal survival and reduces the risk of long-term neurological impairment. In hospital, the procedure should be undertaken at the site of cardiac arrest without moving the patient into an operating theatre. So this diagram basically says that the maternal interventions are the same according to BLS and ACLS algorithms. The drugs given are the same doses. What the obstetric interventions that are changed is by doing, you should do left uterine displacement and then the perimortem caesarean section. Breastfeeding in the ICU. After delivery, early maternal bonding is established and very few drugs are contraindicated in breastfeeding. One should encourage breastfeeding early, even if the mother is on ventilator support, as we can see in this picture. Early maternal bonding has been shown to facilitate rapid weaning from mechanical ventilation, and even in the incidence of lactation failures, rates are low after a major illness. Looking at the impact on women and families, the women almost always are separated from their baby in the ICU, and they usually have significant feelings of loss and grief, and they worry about their own mortality and their baby's mortality, and they usually, after the illness, have difficulty with breastfeeding, caring for the newborn, and bonding with the newborn. And one should not forget the families that are affected, especially the partners. Ethical dilemmas in the obstetric critical care. So critically ill pregnant women can pose ethical dilemmas. We have 3 scenarios here. So the first scenario is when a brain dead patient with a fetus near viability. So the dilemma is, should you prolong the support to maximize fetal viability, deliver the baby, and post-delivery, should the woman be an ideal candidate for organ donation? Secondly, the decision to deliver in critically ill mothers, what should be the ideal time? And if the unstable sick mother is in a term pregnant woman with fetal distress, would delivery be an ideal option to save the baby and risk the mother's life? Looking at co-ICU admissions, the sick mother often delivers a sicker baby, and both the mom and neonate may require intensive organ support. Channelization of resources should be wisely done so that both the lives can be saved. Saving the mother's life should be prime priority, and in the above situation, there is a possibility of a double whammy where losing both the mother and the fetus if delivery is delayed. The above situation warrants experience, wisdom, evidence, and a multidisciplinary approach, including an ethical committee and family input. So in summary, critical illness may complicate any pregnancy. Early warning scores can predict clinical decompensation, and a blood gas analysis is often a very good tool to risk categorize a sick patient. Obstetricians must be familiar with the issues pertaining to care of the pregnant woman with multi-organ failure, and many obstetric disorders may mimic medical disorders. A multidisciplinary approach is key, and the team must decide whether delivery will alter the natural history of the disease process and improve maternal survival. If the maternal condition is expected to improve after delivery, then the consensus decision to deliver either vaginally or by caesarean section must be made. Fetal viability should obviously also be taken into consideration. Hypotension, coagulopathy, and respiratory failure should be treated while preparations are made to deliver the fetus, because timely delivery improves not only the maternal outcome but also the fetal outcome. And lastly, no effort should be spared in the management of a critically ill obstetric patient, because the outcomes are often more dramatically better than expected from the initial severity of the illness. Thank you.
Thank you, Dr. Hassan, for that comprehensive overview, and you kept within time. So are there any questions from the floor or comments? Edward?
It's me. Just talking about respiratory failure and, for example, a patient that is 34 weeks pregnant in respiratory failure. For example, a patient that is 34 weeks pregnant in respiratory failure, and we've seen many of them recover. What will your advice be? She's still
Yes.
antenatal, 34 weeks in respiratory failure. What will your advice be and why?
So like I said in the talk, the initial management of any respiratory failure patient should be the same. Doesn't matter the gestation because mother always takes priority. So it's always circulation, airway, breathing. And with a respiratory failure patient, airway should take preference. So you should always stabilize the mother. Airway, breathing, so stabilize the airway. And once the mother is stabilized, then you can put the baby on a CTG and plan your delivery. If she doesn't get any better and you feel that the gravid uterus is affecting her ventilation, then you can decide on whether you're going to deliver, and if you're going to deliver by cesarean section or vaginal delivery. And then you also need to decide which is going to be the more safer and quicker option for her. But also a multidisciplinary approach with peds, in anesthetics and your obstetric critical care as well.
Let's have a,
You can answer
any
the
other
question.
comments about it? Edward, do you want to make a comment about that?
I just think that majority of the things that you've discussed is patients that can present anyway, and it's obstetric complications, and it happens quite quickly. And I think the wonderful thing is that in our system, a system with a lot of deliveries, limited resources, by identifying people and providing the care in time, our mortality rates are surprisingly low for the pathology that we see. And then sometimes people will think that I'm not going to see this one day in private practice, I'm not going to have to deal with this one day. But it's interesting for me if I look at in the first world too, those mortalities, in the Western Cape, with 2 units, Curtis and our unit, our maternal mortality is actually quite low. Our MMR for the Western Cape is between 50 and 60, compared to those countries where 10 years ago it was 26. The rest of the country is very high. But the point that I want to get to is the mothers in Sweden, in the UK, the mothers that died, most of them were not recognized, or they were recognized, but they deteriorate like this, and then there's not enough time to get the care that they need. And majority of those deaths are also in antepartum and intrapartum patients. And then only a third of the women that die ends up in the ICU because they die before they get to the ICU. And in the first world still, majority of the admissions is after they delivered and they end up on intubated and ventilated, where we prevent intubation and we prevent ventilation. And I think so, you have to, if you don't recognize the patient with potential critical illness, and you don't do something about it, then the inevitable is going to happen.
Thank you. I think that's very important. I think for us, in our labor ward, I think we have to rely on our clinical skills, which you all should always know, so and every patient has an early warning chart in front of them, yellow, red, and that's where we should recognize our sick patients. Pay attention to the quick surface score. It's only 3 things that you need to do, and you can risk stratify your patient immediately. So there's clinical things that are at your disposal. We're exposed to our ESMO and resuscitation, so we can act fairly quickly, recognizing the sick patient and actually appropriately managing the collapse or the impending collapse patient. So I think we do relatively well, even though we are decidedly third world.